Now I'll start with the bile salts first. Now this is the organ, how it looks like. Anatomy organ has not been covered yet. So this is our liver. This is how it looks like. This is the left lobe of the liver, right lobe of the liver. This is the stomach. This is the first part of the duodenum, second part of duodenum, and then it continues at jejunum and ileum. Okay, fine. It's not necessary right now, but what is necessary is this gallbladder. Okay, you can see some greenish shade under the liver. It's just present over there. That is the gallbladder, and this is the bile, which is shown over here. You cannot see through. If you are taking a gallbladder, you cannot see from outside the bile, but just so you understand, this is where the bile is. Okay, this is stored over here. It is secreted from the liver and it is getting stored in the gallbladder. And whenever our body requires for digestion, it is secreted from the gallbladder, as well as sometimes it comes out directly from the liver and helps in the digestion. I'll show you all the tracks and everything, how it comes and how it helps in digestion. Okay. Now, there is introduction. The bile salts are sodium and the potassium salts of the taurocholic acid and the glycocholic acid. Don't write down now. First try to understand. I'll give you time to write down. Okay. The bile salts are the sodium and the potassium salts of the taurocholic acid and the glycocholic acid. These taurocholic and the glycocholic acids are the two bile acids. Okay, they are reacting with the sodium and the potassium, and these are the basic salts that we have in our body. Once it reacts with them, they form the sodium glycocholate and the sodium taurocholate. Like that, they are forming the bile salts. Their functions are to help in the digestion and absorption of the fats. Okay, that is up to this much is their function, and then they get excreted in urine. Okay. But in case of obstructive jaundice, what happens? They are excreted more in urine. Okay. Now this is little contradictory. If it is obstructed, how it is excreting more into urine? Okay. Let me draw a photo, then you can understand. First try to understand this much part. This is liver, fine. This is the hepatic ducts. Then this is the gallbladder, from where this is the cystic duct. Now this is forming the common hepatic duct, common bile duct, sorry. This is the common bile duct. Okay. Now from here the bile salts are coming. Okay. From here also it is coming, and some of the bile salts and bile salt pigments are stored over here. From here also it is coming. Now in normal patient, this should come this way and then help in digestion. Okay. Now let's say over here there is an obstruction. Some stone is blocking here. Okay. Now this bile salt will not be able to come through here. What will happen? These bile salts are easily diluted in the water. They are water soluble. Okay. Whereas the bile pigments are not water soluble. Get this thing first. Bile salts are water soluble and bile pigments are not water soluble. Okay. So bile salts are, just because they are water soluble, they do what? They cannot come through here. This is completely obstructed. They regurgitate back into the liver. They go back because they cannot come out through here. They go back into the liver. Once they are going back into the liver, they are mixing with the systemic circulation that is coming to the liver, like hepatic artery, portal vein. All these are giving the blood supply to the liver. And just because they are water soluble, they get mixed in the blood circulation. Fine, understandable till this much. Once they are getting mixed in the blood circulation, this blood circulation will continue in all over your body, and routinely the blood will go to kidney as well for the filtration. So the blood goes to the kidney as well, along with the bile salts. That high amount of bile salt which should have been excreted, it is not coming out in the gut system or the digestive system. It is going back into the liver and circulating in the blood only. Now this bile salt rich blood goes to kidney. Once it goes to kidney, kidney is not being able to filter the bile salt because it is not his action. It's not his part to filter it out. So kidney will try to filter as much as possible, but it will fail. Ultimately, all those bile salts are coming out in the urine. That is what is written over there. In case of obstructive jaundice, the bile salts are excreted in urine in higher amount. Excess amount of bile salt you can see in urine in case of obstructive jaundice. I tell you again, it is obstructive jaundice. Why? Because this portion is obstructed. If this portion is not obstructed, then bile salt will automatically come on its own path. Okay. So in case of obstructive jaundice, you will get more amount of bile salts in the urine. So if somebody is asking you why bile salts are more in urine, this is the reason. Okay, they get returned to that systemic circulation. They should have came down to the intestine and then helped in the digestion. I'll come into that as well. But they are going back. For now, understand this much. Okay. Now, they are made in liver and excreted in bile. Same thing, they are made in the liver and they are excreted in the bile. The bile is what? Composition of the bile salt, bile pigments, bile acid, everything together we are calling it a bile. Okay, so they are made in the liver and excreted in bile. About 1% is excreted in the feces and the 99% get reabsorbed. Okay, let's say 10 grams of, for an example, 10 grams of bile salts are coming. Okay, from here 1% will be excreting out through the system and rest of the 99% will get reabsorbed again. Means 9.9 gram will again get reabsorbed and 0.1 gram will excrete out. Okay, understandable? Now how it happens? It happens via the enterohepatic circulation. Okay, over here see 99% get reabsorbed in the intestine and return back to the enterohepatic circulation. Now what is enterohepatic circulation? Break the term. Somebody help me out breaking the term. What is entero? Intestinal system or the gut system. Okay, the GI system, that is entero, and hepatic means liver. So any circulation that is happening between the gut and the liver is known as the enterohepatic circulation. This much is fine to understand. So the circulation will be happening between the gut system, GI system and the liver. And how is it happening? Focus here. This is our stomach. This is the second part of the duodenum, third part of the duodenum, and this is the small intestine. Let's say rough. I am not drawing the full of the small intestine. Okay, then the small intestine is meeting into the large intestine. The basic human anatomy that has been covered in 11-12 only. Everybody should know small intestine meeting into the large intestine. So let's say this is the large intestine. This is what? Ascending colon. Okay. Now from here the transverse colon, and then the descending colon. Then the sigmoid and the rectum, and then the anal canal. Fine, nothing new till now, everything is fine. Over here the liver is there. Okay, and these are the ducts coming out and opening into the second part of the duodenum. Fine, this is the gallbladder here. Okay, everything is fine till now. Okay, now see, I am taking food from here, food particle from here. Food particle is coming through here, through the stomach. It's coming down through the duodenum and coming here. This is the second part of the duodenum. Over here the food is. Now there is one more organ, that is the pancreas. Okay, which is helping us in the digestion of the food. Pancreas is releasing what? Pancreatic enzyme over here. Okay. Liver is giving what? Bile salts and the bile pigments through here. Okay, so all the food particles along with the saliva that we are getting from the mouth, then the HCl from the stomach, then the bile salts from the liver and the pancreatic enzyme from the pancreas, then all the foods are getting digested. Fine, forming what? Micelle. Micelle is very easily absorbable food particles. When they are broken down into smaller pieces, they form micelles, which is easily digestible, easily absorbable by our body. Now this food particle will go down through the small intestine, right? Fine till now. When this is going, this is, let's say, jejunum and this is ileum. Fine, this is duodenum, jejunum and ileum. The three parts of the small intestine. Now when it is going down through here, from here only some of the food particles will start getting absorbed. Okay, all this intestine have enterocytes. Enterocyte means in the lumen there are small cells that will try to absorb the nutrients from the food. Okay, and as soon as they absorb it, they will send to the vessels. Okay, blood vessel. They are sending in the blood vessel so that the nutrient can reach to the body. How will it reach? Most of the nutrients are getting absorbed from the terminal portion of the ileum. From the whole process it is getting absorbed, but the largest quantity is getting absorbed from the terminal portion of the ileum. Okay, from here the vessels, the blood vessels all are there, arteries, veins, everything, mostly veins. Okay, they are collecting all these nutrients. Once it is collecting the nutrients, they will send it to the larger vein, then to the larger vein, and this larger vein is known as the portal vein. Okay, fine. These veins are collecting the nutrients and sending to the larger veins. Anybody has any difficulties in understanding till this much? No, right? So these are sending in the larger veins, that is known as the portal vein. Now this portal vein will ultimately take all these nutrients to the liver. Okay, so where my food was? Here. It went down through here. All these enzymes came to help it break it down into smaller pieces, formed micelle, came down through the intestine, and in this process when it was coming down through the intestine, multiple vessels were absorbing the nutrients from the food particles, and once it took the nutrients from the food particles, it is sending, let's say, carbohydrate, fat, protein, whatever you took, that small things it will send through the portal vein to the liver. In the liver, all these food particles will get metabolized. Okay, now this circulation between the gut and the liver, this is the enterohepatic circulation. Okay, now you will understand this bile salt, let's say from here 100 milligram of bile salt is coming. Okay, from here 100 milligram of bile salts are coming. Everything will come down through this tract. Okay, from here these veins are going. These veins will send 99 milligram of bile back to liver again. Understandable? And 1 milligram of bile will come back through here, excreted. That is the 400 milligram per day. Fine? Anybody has any doubt over here? Enterohepatic circulation concept is fine? Okay? Okay. Now this is Hess sulfur test. Okay, Hess sulfur test we are doing to identify if there is bile salts are present in the sample or not. Now the observation. Observation is the same thing. Sulfur powder sinks rapidly in the urine containing the bile salt, but do not sink in the test tube which is containing the distilled water. Same thing. Precaution, do not shake the test tube and let them stand for few minutes, otherwise the false result will be produced. Okay, so don't shake the test tube, already mentioned. Do not use excess amount of sulfur, otherwise it will settle due to its mass, mentioned. And use the fresh sulfur so that it is moisture free. Fine. If it is containing the moisture, it will give you the false result. Okay. One more thing that you have to keep in your mind, that urine preservative that we are using, thymol, that can also give you false test. Why it is important? Let's say somewhere you are doing the test, you have prescribed someone to do the urine test for the bile salts, and the patient gave the urine sample. Now the person who is collecting the urine sample, they don't know. Okay, you know, but that person don't know. That person added what? Thymol to preserve the urine, because the urine have to be sent to somewhere far away from the lab, and they have added the thymol. What happens once you get the urine sample? Once you are doing the test, you will see that the sulfur is settling down. That means bile salts are present, but actually there is not present. It was the mistake of the collector who was collecting and who have added the preservative as thymol. So whenever you are collecting a urine sample and the test is for the bile salt, do not add thymol as a preservative. You can use alternate things. What are the alternate things? Anybody remember from the first class? What was other preservatives? Something with chloroform. Can anybody recall? Chloroform, thymol was there. Did not go through the slides, older slides. Okay, anyway, just remember that whenever you are preserving the urine sample, do not add thymol. If the test is for bile salts, it will give you a false result. Okay, write it down. Over here two pictures are also there. This contains the distilled water. Over here you can see the sulfur is just floating above the water. But in case of the urine sample, as soon as the sulfur comes in the contact of the urine, it sinks down. Okay. This test we are doing for bile salts. Okay, don't confuse with bile pigments. Okay. Done. How many of you are still writing? Okay. Done? Okay. Now there is some clinical significance. What are the clinical significance? They get regurgitated into the systemic circulation in hepatic and post-hepatic jaundice. Now tell me, what is jaundice? Yellowish discoloration of the skin, sclera. That. Why it happens? Bilirubin. What is the normal level of bilirubin in our body? 0.2 to 1.2. 0.2 to 1.2 milligram per deciliter. Fine. This is the normal level. Okay. Now in this bilirubin, this is the total bilirubin. Okay. There are two forms. One is direct form, another one is the indirect form. You will get to know eventually. Now these two bilirubin, when the bilirubin level increases more than 1.2, we call it jaundice. What are the processes which this bilirubin can increase? First of all, there is two terms, that is hepatic and post-hepatic jaundice. What is hepatic? Hepatic means this is liver. Some pathology is in the liver that is causing the jaundice. That is hepatic jaundice. What is post-hepatic jaundice? Something outside the liver. Okay, that is causing the jaundice. Probably some obstruction that I was mentioning beforehand. That is post-hepatic jaundice. Can be obstructive jaundice as well. What is pre-hepatic jaundice? Exactly, when the RBCs are breaking down, because the RBCs are not even coming to a liver. Before that only, in the spleen, which system is responsible for the destruction of the RBC? Anybody knows about the reticuloendothelial system? RES, in short we mention it as RES, reticuloendothelial system. What it does is, reticuloendothelial system looks after the unwanted products in our body. Whichever unwanted products are there, macrophages will destroy. They will destroy the RBCs. Once the RBCs are getting destroyed, what is the normal lifespan of an RBC? 120 days. After that, it will normally get broken down. How? Once the RBC breaks, what it releases? Hemoglobin, because it carries the hemoglobin. So once the hemoglobin also breaks down, what it forms? Heme and globin. One is the heme, another one is the globin. Now from heme, what it happens? It forms one thing. Can anybody tell me? No, I am talking about bilirubin pathway, not the iron pathway. Iron pathway, that is completely separate. That is not related to my topic. It first produces biliverdin. Yes, very good. Biliverdin. And then the biliverdin gets converted into bilirubin. Exactly. From here, the bilirubin is coming. Can anybody tell me two enzymes are responsible over here? Heme oxygenase. Yes, heme oxygenase. Heme oxygenase. Very good. It shows that you are studying at least. And from the biliverdin, bilirubin is coming. Which enzyme is responsible? Can you tell? I'd be happy if anybody can tell. Anyone? Who is telling? Who is telling this? Yeah, very good. Lovely. This is biliverdin. You are the first one in your batch who answered it. Okay? And you are the first one who answered this one. Nobody answered till now. So heme oxygenase is helping from heme to biliverdin, and biliverdin reductase is helping from biliverdin to bilirubin conversion. Okay, this way we are getting the source of bilirubin normally. Now this bilirubin will get circulated in the liver and through our entire system. Now what is happening? In hemolytic jaundice, this bilirubin is increasing. Okay, one thing, that is the hemolytic jaundice we are getting. Now in case of hepatic jaundice, what is happening? The liver is the one which is regulating this bilirubin. Okay, it should reabsorb from the system and again release. Again reabsorb from the system and again release. How it will do this, I'll tell you. Okay, but for now remember that liver is taking up and releasing when it is as it is required. Now if the hepatocytes are damaged, do you think that this process will be normal? No, obviously hepatocytes are damaged. That means they cannot regulate the bilirubin reabsorption and releasing properly. So that time bilirubin will again increase, and that is the hepatic jaundice. Fine. In case of obstruction, what is happening? The bilirubin can't get out from here. And what I told, bile pigments are non-water soluble. They get water soluble only they are converted into the direct bilirubin or conjugated bilirubin. Then only they are water soluble. Before that, they are not water soluble. So bile salts was going back into the liver. Bile pigments cannot come down. They cannot go back also into the systemic circulation. So that's why in case of obstructive jaundice, this direct bilirubin or the conjugated bilirubin increases more and more. That is known as the obstructive jaundice. So three differences. First one is the hemolytic jaundice, which is happening because of excess destruction of the blood. Let's say somebody is having A positive group of blood and you have transfused A negative group of blood into there. Obviously hemolysis will be there, and that hemolysis will release more and more amount of bilirubin. The patient will suffer jaundice as well. Okay, other than shock and all the symptoms, that is the anaphylactic shock and all, patient will have the jaundice as well because of the destruction of the hemoglobin. That is hemolytic jaundice. Okay, there are some congenital condition as well, like G6PD deficiency and all, phosphofructokinase deficiency and all. In those cases also people can get. Okay, that is a hemolytic jaundice. The main motto of my discussion is hemolytic jaundice is completely separated from all of this. In case of hepatic jaundice, the liver tissues, that the hepatocytes are not working properly, that's why you are getting jaundice. In case of obstructive jaundice, the pathway is obstructed, that's why the bile pigments, that is the bilirubin and the biliverdin, cannot come down. That is why you are having more amount of direct bilirubin inside your liver, and which is increasing the bilirubin level in the body, and that is causing the jaundice. Fine, this much is understandable. Okay, now see what is written over here. They get regurgitated into the systemic circulation, the bile salts, and hepatic and the post-hepatic jaundice because of intra and the extrahepatic biliary obstruction. Over here we are still talking about salts only. Okay, over here we are still talking about salts. That's why the salts are getting back into the systemic circulation. In case of hepatic and post-hepatic jaundice, means if there is any blockage in the liver, any blockage outside the liver, it will go back into the liver again. It cannot come out. Okay, and then they are water soluble. That's why they get mixed with the systemic circulation and then get excreted out in the urine. In case of hemolytic jaundice, they are absent in urine. Why? There is no pathology here. Okay, so bile salts are coming down as it is. Fine, and getting reabsorbed from the enterohepatic circulation, 99% of it. Hemolytic jaundice is a complete separate thing. That's why in case of hemolytic jaundice, bile salts are absent in urine. There is no point of bile salts coming into the urine. Understandable? In hepatic jaundice, some bit of it will be present in urine. Why? Because the hepatocytes right now that was coming from the enterohepatic circulation, that 99% which was getting reabsorbed from the system, hepatocytes are damaged over here in the hepatic jaundice, right? Focus on the word. Hepatic jaundice, liver is damaged. That's why the bile, that salt that is coming from the enterohepatic circulation, now the hepatocytes are not being able to reabsorb them properly. So some amount of it will get out in the systemic circulation and will come in the urine. So some will come in urine. Okay, they are present, but their excess in obstructive jaundice. In case of obstructive jaundice, everything is going back, nothing can come down. Everything is going back into the liver. That's why the amount of the bile salts are more in excess amount in the urine. Anybody has any doubt in understanding this much part? Anybody has any doubt? Please raise your hands. Okay, you can write it down if you want. And the purpose of the test is to assess the liver function. Obviously, if we cannot estimate the hemolytic jaundice from here, from this test. We are assessing if there is any pathology, if there is any obstruction or any hepatic tissue damage is there. Fine? Please write it down.
Sir, can you repeat the obstructive jaundice part? How it is?
Excess in urine. Okay. Let's say over here is the obstruction. You can see I have drawn two stones. Okay. These are two stones which is obstructing this part. This is what? Bile duct. Okay. Common bile duct. Right. Written over here. This is bile duct. So bile salt was supposed to come through here. Okay, everything is coming through here only. Bile salts, bolo, bile pigments, bolo, everything is coming through here. Now let's say the bile, this portion is blocked. Bile salts cannot come down. This will regurgitate back into the liver. Okay, and these are water soluble. If these are water soluble, they will easily get mixed with the liver and then into the systemic circulation. That is the blood circulation which is happening in the liver. Fine, this much portion is fine. So if it is coming in the systemic circulation, that is in the blood, then the blood will go to kidney as well to get filtered out. Every other minute, every other second, the blood is circulating through the kidney to get filtrated. Now the kidney's function is not to filter out bile salts. That is not kidney's function. But it will try to do some, to some extent. But rest of the bile salt will come back into the urine. That is what the filtration is. Let's say over here you have put your glomerular basement membrane. Your blood is coming through here along with the bile salts. Okay, and if it is getting filtered out, it will get reabsorbed into the system. And if it is not filtered out, it will throw back into the urine. Okay, now bile salts are not getting reabsorbed, so this will come into more and more into the urine, more and more into the urine. Fine, that is why it is excess in case of obstructive jaundice. But in case of hemolytic, the pathology is completely different. No role of bile salts into it. That they are coming normally and they are absent only in urine. Whatever is coming down, getting reabsorbed, going back to the liver again. No, nothing will come into the urine because 99% is getting reabsorbed again. And only 1% is coming through after metabolism. Not coming in urine. But in case of hepatic jaundice, 99% is going back to liver. This is fine, but liver is not being able to take it up because the hepatocytes are damaged. Fine, if the hepatocytes are damaged, they cannot take it out. Obviously, some bit of will come in the urine again. Understood? Yeah. Everybody is done with writing? Okay. Now, test for bile pigments. So, in the lab, you people are going to do only the haze sulfur test. Okay, and that is what will be asked in your exam as well. For bile pigments, we will be doing one test that is known as the Fouchet test. Which test? Fouchet test. That you people won't have to do. I will just give you a demo of the Fouchet. How it is done. You have to know the principle, the steps, what is the reason we are doing it, and what is the reactions taking place, and the reagents as well. Basically, everything you have to know, but you don't have to do it. Why? Because sometimes the test might not come positive as well, depending upon the solution we are using. Okay. Now, test for bile pigments. This is how the bile pigments metabolism will occur. Little difficult. I'll try to break it down for you people. If you are not understanding in any step, please raise your hand and ask. Okay. First of all, what happens? I mentioned about the reticuloendothelial system. What it does? It throws out the unwanted product from our body, or it metabolizes them, breaks them, and then discards it. Okay. What happens in the reticuloendothelial system? RBCs are getting broken down. RBCs broken down releases hemoglobin. Hemoglobin broken down releases heme and globin. Same thing. Then the heme, from heme first biliverdin, then bilirubin. That is known as the unconjugated bilirubin. That means it is a free bilirubin now. Okay, but there is a problem with this bilirubin. This bilirubin cannot move. Okay, it is not easily transportable. Okay, it is just there. It produced and it is just there. But the bilirubin wants to come out of this RES, reticular endothelial system. What it does, it comes into the bloodstream and binds with the albumin. Albumin is what? Protein that is present in our body. Now it is binding with the albumin and forming what? Albumin bilirubin complex. Okay, you call it bilirubin albumin complex or albumin bilirubin complex, same thing, but it is still unconjugated. Okay, this is known as the indirect bilirubin that I was mentioning in the total bilirubin section, that there is two forms of bilirubin. One is indirect bilirubin, another one is the direct bilirubin. Indirect bilirubin is the unconjugated form of the bilirubin, and conjugated form of the bilirubin is known as the direct bilirubin. How it is becoming conjugated? Once this bilirubin through the bloodstream, it will go to the liver. Before it was not being able to go into the liver because it was not getting the mobility, that movement it was not getting. Once it is binding with the albumin, now it can easily move. Okay, it is going to the liver, and there is one enzyme, that is the uridine glucuronyl transferase. Uridine glucuronyl transferase. This enzyme will do what? This enzyme will convert the unconjugated bilirubin into conjugated bilirubin. That is known as the direct bilirubin. Fine. Now this direct bilirubin from the liver will come out how? The same tract. The same tract. Through here it will come down. Fine. Once it comes into the gut, there are gut bacteria which are there in our gut, which is helping in our digestion. There are two types of bacteria in our gut. One is good bacteria, one is bad bacteria. Okay. Good bacteria will help in our digestion, and bad bacteria will give us gastropathies. Okay, that diarrhea and all everything we are getting for the bad bacteria, but good bacteria are helping in our digestion. How in digestion? This is how they are helping. They are converting the conjugated bilirubin into urobilinogen. Okay, once this urobilinogen is there, urobilinogen is having three outcomes. In three way it is ending. The termination of the urobilinogen happening in three way. 80% of it is converting into stercobilin. Okay. We all know our stool color is yellow. Normal stool color is yellow. It's yellow because of the presence of the stercobilin. Okay. Normal urine color is pale yellow. Why is it pale yellow? Because of urobilin. So all the responsible particle is urobilinogen, which is forming into urobilin, giving the pale yellow color to urine, forming into stercobilin, giving the yellow color of the stool, and 80, 82 done. Rest of the 18% is going back through the enterohepatic circulation. The same enterohepatic circulation going back to the liver again. Fine. Over in case of bile salt it was 99%. In case of urobilinogen, how much it is? 18%. 18% is going back into the liver again, and the same circle goes on. Fine. This much part understandable. Anybody has any difficulties in understanding the chart? Okay. You can write it down if you want. This all will be taught to you in pathology again. Okay. Now this is the Fouchet test. Okay. What we are doing in the Fouchet test is, what is written over here? Barium chloride reacts with the sulfate radical which is present in the urine and forms the barium sulfate. Bilirubin, if present, it adheres with the precipitate and is detected by the oxidation of the bilirubin, which is yellow in color, into biliverdin, which is green in color, with ferric chloride in presence of the trichloroacetic acid. Anybody understood anything from here? Can anybody tell me? No, right? Okay. So this is the bookish term of the principle. Now let us just break it down and understand what they are actually trying to tell. Okay. Let's say this is an urine sample you have taken. Okay. This is the urine sample. In normal urine sample, do you think we should have sulfur particle in normal urine sample? Is it normal to have it or abnormal to have it? Normal. This is a normal constituent of the urine, which will be there in the urine. But in case of lab-made sample, we don't have this sulfate in the sample. Obviously, we are making the urine sample. How can sulfate be there? Okay, so we have to add magnesium sulfate into the test. Okay, it is not mentioned over here because we are suspecting that we are taking a normal urine sample. That is why it is not mentioned over here. But in your lab, if it's a lab-made sample, you have to add mag sulfate as well. Otherwise, the test will not take place. Okay, that's just for your knowledge. not necessary for the topic. What is happening? In the urine sample, there is sulfate. Now we are adding what into it? Barium chloride. Okay, barium chloride will react with the sulfate particle and form what? Barium sulfate. Okay, now barium sulfate is there, and let's assume over there is bilirubin. Because of that only we are doing the test. Let's assume there is bilirubin. This barium sulfate, after that we have to add glacial acetic acid. Glacial acetic acid. This acetic acid will give the medium acidity. It will make the medium acidic, as well as it will help this barium sulfate to precipitate along with the bilirubin. Fine. So this barium sulfate, bilirubin and the glacial acetic acid, everything will precipitate at the bottom of the test tube. Now this precipitate will take some time. We don't have that much amount of time. So we will take that mixture and do what? We will take a conical flask and we put a filter paper into it. Okay. What is a conical flask and filter paper? Over here you can see. See the filter paper. Okay. We are putting the filter paper into it and keeping it here. Now that mixture that we have prepared, that solution we have prepared, we will put it in the filter paper. The clear fluid will fall below and the supernatant which is there, that will be settling down in the filter paper. Once it is dried up, we will take out the filter paper, means all the solute has fallen down. Then we will take out the filter paper, put it on a clear tile, white tile, so that we can see the color. The color over here, it should be yellow in color. Okay. If this yellow color is there, after that on it we will add 1 drop of Fouchet reagent. The test that we are doing, there is a Fouchet reagent. We will add 1 drop of Fouchet reagent into it. And as soon as we add the Fouchet reagent into it, it will convert into green color. Okay. So this is what we are looking for. If this color change is happening, then bilirubin is present over there. That means this was the bilirubin which was giving the yellow color, which oxidized into biliverdin. Okay, biliverdin will give the green color. Okay, now if the bilirubin is not there, that means this yellow color will not turn into green. Okay, and Fouchet reagent contains what? The Fouchet reagent that I have mentioned. Fouchet reagent contains ferric chloride, FeCl3 plus trichloroacetic acid. Okay, these two are the composition of the Fouchet reagent. Now read the principle again. See what is written over there. The barium chloride reacts with the sulfate radicals. The barium chloride is reacting with the sulfate radicals and forming what? Barium sulfate. Now if the bilirubin is present in the solution we are suspecting, then it will adhere with the precipitate. This is the precipitate. After adding glacial acetic acid, this makes the medium acidic as well as it precipitates along with the bilirubin. Once it precipitates, it is detected by oxidation. Oxidation is done by the Fouchet reagent. Oxidation is done, see over here, the oxidize. Okay, the Fouchet reagent is oxidizing what? The bilirubin. It's oxidizing the bilirubin and forming biliverdin, and the color changes there. And this thing what is written over here, in the presence of the ferric chloride and the trichloroacetic acid, that is the Fouchet reagent. Okay, anybody has any difficulties understanding the principle now? That has been broken down, I guess. Anybody, if have any difficulties or anything to any query, please raise your hand and ask. In the exam hall, if we are asking you the principle, at least you should be able to answer it in this way, what is happening in the test. If you are not being able to use the exact bookish term, at least be able to answer in that way, what is happening. To you people, these words can be little difficult to by heart in the exact word by word can be difficult. So understand in this way at least what is happening in the reaction. First we are adding barium chloride which is reacting with the sulfate particle of the urine. It's forming barium sulfate. Then we are adding glacial acetic acid, and along with the glacial acetic acid, along with the barium sulfate, the bilirubin particles are precipitating. Then we are just filtering it out. Once we are filtering it out, on the filter paper, the supernatant will be there and the clear fluid goes down. We are taking out the supernatant which is yellow in color. We are adding 1 drop of Fouchet reagent into it and it is changing the color into green. If the color change is happening, that means the bilirubin is getting oxidized into biliverdin. That means bilirubin is present. And if the color change is not happening, that means there is no bilirubin. Fine. Those who are still writing, please just focus over here. I'll show you the demo of the test, okay? This test you won't have to do in the lab. I'll just give you a demo, okay? So this is what? This is what? Urine sample. We will take 5 ml of urine sample, okay? Okay, then we have to add what? Barium chloride into it. How much? Same 5 ml. Okay, done. Then we have to add what? Glacial acetic acid into it. How much? 2 drops of it, okay? Now you can see some coagulum, some turbidity is there, right? So this is precipitating. Let it precipitate a little. Okay, till that time we see the steps. This is Fouchet reagent, nothing to write from here, just an image. Fouchet reagent contains what? Ferric chloride, FeCl3 and trichloroacetic acid and barium chloride. These two are the reagents we are using, okay? And this is the procedure. Take 5 ml of urine, add 2 drops of glacial acetic acid into it, 5 ml of barium chloride into it, and the pigments will precipitate along with the barium sulfate. Fine. Then we have to filter it out and spread the filter paper on a porcelain tile. Porcelain tile means in a clean tile where you can see the color properly. Okay. Once you see it, you add 1 drop of Fouchet reagent into it. Okay. And the color will change from yellow color to green color. Okay, this is where it is. The sample is there, some animated photo is there. You have filtered it out. The clean supernatant is there, and the soluble part is there. Then you take out the filter paper, spread it in a porcelain tile. This is how it will look like, the yellow color. And once you add the Fouchet reagent into it, it will turn into green color. Okay. Now this green color, the blue green which is written over here, this will be a tinge of blue. Don't expect that it will be a green like a leaf. Okay, tree leaves not like that green, it will be just a tinge of blue. Okay, sometimes you can get this blue color over here as well because of the defective sample. If we are using some sample which already contains biliverdin, then over here only you will get the bluish green color. Okay, that is why to some extent when you are performing this test, if the samples are not made properly, then this can be green beforehand only. In my last class also it was just something like that only. Okay, so the main motto of the test is to how to do the test and what things you will get. Okay, I'll try to see this color. The color of the urine is already little greenish type. Okay, so to some extent it contains bilirubin as well as biliverdin. So the test that I am doing might not come as yellow as it is showing over here. But if it is a proper urine sample, then it will come this yellow only, because in urine you will not get that much amount of biliverdin. You will get mostly bilirubin only. Somebody who is having jaundice, they will have higher concentration of bilirubin, so much that the sample will be completely yellow only, not that greenish. Okay, yeah. If you want to write it down, please write it down. Let me filter it out till then. Now, in recent days, we are always using some dry chemistry. What is dry chemistry? What is dry chemistry? Anyone? Everyone don't start murmuring.
You're seeing dry form.
What?
Use of chemicals.
In the dry form, exactly. We are not using any liquid form. Okay, where you some strips are there which is already coated. কোন স্যাম্পলটা দিছিল আজকে?
ওইটা
আজকেরটা দিছো স্যাম্পল? গ্রিনিশ স্যাম্পল অলরেডি। গ্রিনিশ কালার।
ওইটাই আছে।
ইয়েলো আসলো না সকালে তো?
না মানে ইয়েলোই আছে বাট
পরে গ্রিন হয়ে গেছে। ওকে ঠিক আছে চলো এটা লিখো। Okay, what I was saying, some chemicals are there which is already coated in the strips. Okay, why we are coating? With that thing that some particles are there, we are suspecting some particles are there in the solution. This particle will react with the specific reagent which is coated in the strip, and then they will show some color change. Okay, over here we are trying to identify bilirubin. For bilirubin, the strip is coated with what? 2,4-dichloroaniline. Okay, this is the reagent, this is the dry reagent which is there in the strip, which is coated in the strip. Now as soon as you put the strip inside the sample, if it is containing bilirubin, the bilirubin will react with the 2,4-dichloroaniline and it will form azobilirubin. And this azobilirubin is the thing that is giving you these different types of colors. And depending upon the colors, you can comment how much concentration of bilirubin is there. Okay, that is an approximation. That is why these all tests are qualitative tests or semi-quantitative, you can say. You can have an approximation value but not the exact valuation. So this is the azobilirubin which is giving you the color, and this is the dry chemical which is there, which is coated in the strip. Okay, but there is a limitation of this test. The limitation of the test is this test can estimate only the direct bilirubin. If there is indirect bilirubin which is increased, indirect bilirubin can be increased in hemolytic jaundice. If more and more amount of blood are getting lysed, more amount of bilirubin will form. But do our body have that much amount of albumin as well to bind with it and make it conjugated bilirubin in the liver? No. So that is why more amount of unconjugated bilirubin will increase in case of hemolytic jaundice. Okay. So if you are suspecting somebody is having hemolytic jaundice and you are doing this strip test, you might get a negative result. You might get a false result. Okay. But in case of obstructive jaundice, where the direct bilirubin is only increasing more and more in quantity, over there you can identify with the strip test. Fine? Okay. Anybody has any doubt till now? Okay, can write it down.
Obstructive jaundice, how the direct bilirubin increases, because it cannot
Come down.
pass through the,
It cannot come out from the liver only. The direct form, it is forming in the liver.
but it cannot pass through the portal circulation because
It cannot pass through the portal circulation. It is not water soluble. Okay, the bilirubin which is present in your circulation, that will only be there. The excess amount of bilirubin will be there in the liver. The amount of bilirubin that is getting produced in the liver, which will be there in the circulation, but the excess amount that is forming, it will be present in the liver. To some extent it will be there in the blood. Okay, but in case of bile salt, it is mixing up with it. In case of bilirubin, it is not mixing up. It will be only there, and it can be present in the blood circulation only. The excess amount which is producing in the liver, everything will not be there in the blood. Fine?
Sir, is the meaning that plus
Means how much amount of bilirubin is there. Let's say 1 mg, let's say 2 mg, and then 4 mg. The more the bilirubin, the deeper will be the color. The first one is little bit over here, it is written pinkish tan color. Okay, so I have little less idea about these colors. Females have much more clarity of shades. They can differentiate 10 shades of pink. I cannot say. For me, everything is pink only. So these are little darker version of pink. So I don't know the exact name of the colors. I can't say it. I don't have the idea. But yeah, these are little darker shades of pink for me. And for every one of you, you can understand that. If anybody has better idea of these colors, please enlighten me. I'll be happy to do that as well. But I don't have the exact name of the colors. So it is little darker form of pink. The more darker it is, the strips are already coated with the colors. Okay, you have to just cross check with the colors, which color is it matching with, which color it is resembling like. As soon the color it is resembling like, that is the result you are getting. The strip containers has these 3 colors, and the strip you are dipping and you are getting one color. Now you have to compare with the container's color with the color that you are getting. Whichever color is matching, that is the result you are getting. That's all. Okay, now there are 2 conditions. The name of the condition, one is hyperbilirubinemia, another one is the hyperbilirubinuria. So common terminologies ma'am has already told you people in your classes. If anemia is there, that means it is present in the blood. If urea is there, it is present in the urine. If CC is there, it is present in the systemic circulation. That's all, something like that. So hyperbilirubinemia means more amount of bilirubin is circulating in the blood. Hyperbilirubinuria means more amount of bilirubin is present in the urine. Okay, over here we are talking about urine sample, that is where I'll be focusing in the hyperbilirubinuria, not in the EMEA. EMEA will be taught to you in medicine as well as in the pathology. Okay, fine. Now, what are the conditions where you can get hyperbilirubinuria? Anybody has any idea? So far, whatever we have discussed from that, where you can get more amount of bilirubin in the urine? Obstructive jaundice and hepatic jaundice. Yeah, hepatic jaundice means some pathologies in the liver. What do we say? Any pathology, any inflammation in the liver means hepatitis. Itis means inflammation. The word itis means inflammation. Hepatitis means liver inflammation. So hepatitis can be because of viral infection, can be because of other pathologies as well. Viral infection like virus, hepatitis A, B, C, D, E, all are there. They all can cause hepatitis. Okay. Now obstructive jaundice one done. Then some people can get some disease because of chronic alcoholism. रोज दारू पीता है, क्या होता है उनको? Cirrhosis, yeah. Cirrhosis is one more condition. Any other liver pathology. It can be because of some trauma induced as well. Let's say somebody is driving a car or somebody is driving a bike very fast and they had an accident and they got injury to the liver. They will also get inflammation in the liver and that will also present like hepatitis only. So that is any form of liver disease, any form of liver cirrhosis, hepatitis, obstructive jaundice, and one more condition is there. Some drugs, medicine that we are using, which is metabolized in the liver, and if you are taking excess amount of it, that can also cause hepatitis. Some examples, can anybody tell me? Most commonly we take what? Paracetamol, right? Paracetamols are getting metabolized in the liver. Okay, so if you are taking more amount of paracetamol, somebody is thinking of committing suicide and took 10 tablets or 15 tablets of paracetamol. That is toxic dose for liver. That will cause liver damage. Okay, some female is taking OCP. OCP is oral contraceptive pill. They are regularly taking OCPs. If somebody is taking OCP for more than 4-5 years continuously, which in the rural places female takes as well, they don't use the modern techniques of contraception and they are using on the pills, and that can cause damage to the liver as well. So they all can have this bilirubinuria after the liver gets damaged. Okay, so these are some examples of the drugs. There are many more drugs. When you will come to pharma, you will get to know. Okay, so all these drugs can cause liver damage if taken for a prolonged period of time or in a higher dose. Somebody is taking paracetamol twice or thrice a day in the dose, adjusted dose, like this much is the adjusted dose you have to take, and you are taking within this much. This might not hamper, but somebody who is taking in a larger quantity, that can damage. Okay, and the most commonest cause of liver damage in our India is this drug only, drug induced. Okay, and most common drug is paracetamol only. After that comes the viral infection, hepatitis, that is caused. Okay, now these are the causes of the bilirubinuria. First is liver disease, any form of liver disease, liver cirrhosis mostly because of alcohol, hepatitis, viral infection as well as drug induced, and then obstruction of the biliary tract. There are 3 images. This is how the normal liver will look like, healthy liver, and this is how the cirrhotic liver is looking like. In cirrhotic liver, what is happening? It is getting fibrosed. First of all, the cells are getting inflamed. Once the inflammation is resolving, they are getting fibrosed, means they are narrowing down, getting more smaller. Okay, and they don't function properly. That is why in cirrhosis liver, you are having all these problems. Okay, and then there is one image of obstruction. Till now, I was mentioning all the obstruction with the example of a stone. It's not mandatory that every time it will be stone only that is causing obstruction. It can be some cancerous tissue as well, which is causing the obstruction. Some other pathologies as well. Let's say, giving you one image, let's say this is the duct which is coming from the liver. Okay, and this is where it is opening in the second part of the duodenum. And over here I said that there is an organ called pancreas. Okay, now this is pancreas, this is the common bile duct, and this is the liver. Now what is happening over here? There is a cancerous tissue. Okay, some pancreatic cancer, or this duct is there, that is a periductal cancer, the duct that is opening from the pancreas. Okay, periductal cancer, which is also known as the periampullary cancer, ampulla of Vater is there. All of this will be covered in the anatomy, and all this cancer does what? These are growing over here, and once they are growing, they will compress this duct. Okay, if this growth, these cancerous tissues are compressing the duct will be closed. Obviously this won't be able to open it up. So if the ducts are closed, nothing will come down. Again it will resemble like a obstructive jaundice. And the blood picture that you will get in the LFT finding or the urinary finding, you will get the finding like a obstructive jaundice. So all the time it is not necessary that it have to be stone only. The stone is one of the commonest one, that is from the gallbladder. We all know that the gallbladder stone. Okay, one of the stone or the two or three of the stones are getting dislodged from the gallbladder along with the bile and getting stuck over here in the duct, and they are blocking. That is one of the commonest cause, but not every time. It can be cancer as well, it can be other pathologies as well. Okay, everybody done with writing? Okay. Now test for urobilinogen. So our two tests is done. One is the haze sulfur test that you all are going to do in the lab. Second one is the Fouchet test. Fouchet test finding you people did not see yet. Okay, let me see. It's still there. Let it settle down. Okay, till then we cover it up. Test for urobilinogen. What was urobilinogen? Where did we see the term urobilinogen? In the gut. In the gut, where the direct bilirubin is getting converted into urobilinogen by the gut bacteria. Okay, so we have to measure the urobilinogen and what is the significance of it. Okay, let's see. The test is Ehrlich test, which we are doing to identify the urobilinogen. Urobilinogen gives a pink color with para-diethyl aminobenzaldehyde in an acidic medium. Normally the fresh voided urine gives pink color. Okay, over here there is actually nothing to understand. First of all, the urobilinogen is there and there is Ehrlich reagent as well. The Ehrlich reagent contains this thing, the para-diethyl aminobenzaldehyde. Okay, in composition with HCl. HCl is giving what? That acidic medium. Here it will be acidic, not acetic, it's a typing error. So para-dimethyl aminobenzaldehyde along with HCl is known as the Ehrlich reagent. Okay, now once it mixes with the urobilinogen, it forms a pink color. So if there is a pink color that is appearing, that means urobilinogen is present. As simple as that. What is the procedure? Take 5 ml of urine, add 5 ml of Ehrlich reagent into it and wait for 10 minutes. And then again add 10 ml of saturated sodium acetate solution and then you see development of pink color which darkens on adding sodium acetate indicates the presence of the urobilinogen. Okay, now how you have to remember this procedure? What is the one easy rule is there that I can tell you that you can remember is 5 5 10 10. Remember that much, 5 5 10 10. 5 ml of urine, 5 ml of Ehrlich reagent, then wait for 10 minutes and then add 10 ml of sodium acetate. Fine, this much you have to remember, that's all. Nobody will ask you more than this much from the Ehrlich test. Okay, we are not even doing this test in the labs as well right now. Okay, just theoretically you have to know which test we are doing for urobilinogen and how it is done, just so you have a rough idea. And this test can be positive with one more product as well. One is the urobilinogen, another one is the porphobilinogen written over here. See, the porphobilinogen, if somebody is having porphobilinogen, they can give this test positive as well. Do you think that me, you, everybody of us is having porphobilinogen in our urine, in our system? We don't have. We have urobilinogen only. Okay, but there are some patient who is having porphyria. Porphyria is a disease the patient is having. In them, this porphobilinogen is there, more in quantity. And in those patients, you can get this Ehrlich test positive. Okay. What does normal Ehrlich test positivity means? If the Ehrlich test is coming positive means what? Present, and that is normal. Everybody will have, fine. But if it is absent, then it means what? Abnormal. What abnormality is there? Obstructive jaundice. Yes. If the urobilinogen is not there, that means it is not coming from the liver. Some obstruction is there, that is why urobilinogen is not there. That is what it indicates. If the Ehrlich test is negative, so more than the positivity, this test's negativity is more important. If the test is coming negative, that means there is some defect in the patient. If it is positive, means it can be because of urobilinogen, it can be because of porphobilinogen, we don't know. It can be normal as well. It will be more in quantity in case of hepatic jaundice, when the quantity of the bilirubin will be more and the urobilinogen in the gut will be also more. That time the test result can be more in quantity. That is hepatic and hemolytic jaundice. But in case of obstructive jaundice, it will be completely absent. So we can only rule out if obstructive jaundice is there or not. Okay, rest of the things everywhere it will be positive only. Whether it is normal, whether it is more in quantity hemolytic or hepatic jaundice, it will be positive only. Everywhere it will be positive. Okay, please see here. Can you see some yellow color tinge over here? Is it visible from the back? Some yellow color tinge is there. That means we are suspecting some bilirubin can be there. Now we have to add the Fouchet reagent. We have to confirm it if it is converting into green color or not. Okay. Let it just settle down for some time. Now clinical interpretation. Urobilinogen is increased in urine in hemolytic and hepatic jaundice. Okay. Urobilinogen will be increased because of hemolytic and hepatic jaundice, but we cannot estimate it with the earliest test. Why? It's a qualitative test. We cannot estimate how much it is increasing more. Only color change will be there. That's all. And color change means urobilinogen is present. That is why, but urobilinogen will increase more in quantity in case of hemolytic and hepatic jaundice. Okay. But it is absent in case of obstructive jaundice. It will not come down in the gut, and that is why it will be completely absent. And it gives pink color, also given by the porphobilinogen, and it is significant of porphyria. Those patients who is suffering from porphyria, they will have more amount of porphobilinogen other than urobilinogen as well, and that will also give the same test positive. Okay. Now let's see, the green color is little prominent over here. You can see over here, this color. See, not over here at least. These are still little yellow, but over here you can see little green is there. Come closer and see.
Yes.
Yeah? That this much tinge will only be there. You cannot see the exact green color. Okay, don't even expect that it will be completely green. Okay, so some bit of tinge will be there. If I add little bit more Fouchet, probably the yellow color might change. Let me see. See. So that's all. Over here, I don't know whether you can appreciate it or not. Can you see that yellow tinge is not there that much? Okay, some greenish light, matlab, how to say, some greenish tinge will be there. If you can come over here and you can see you can estimate it. This portion, okay, this side. See? Okay. Some greenish tinge will be there. So that confirms the presence of bile pigments. Yeah, bile pigments. Okay. Done with writing? Done with writing? Okay. Now some question and answers. This is my favorite section.
Sir, it will be better if you explain the thing in a slow way. He said too fast, so it was unable to catch him.
Okay, fine. Which portion? The bilirubin formation or the bilirubin that was there? The bilirubin metabolism? The formation. Okay, fine. Tell me like that. If I am going fast, tell me. I'll slow it down. I'll again repeat it. First of all, see, RBC is there. Okay, RBC is breaking down and forming what? Hemoglobin. Okay, this hemoglobin is breaking down into two portions. One is heme portion, another one is the globin portion. Fine, understandable. Now this heme portion is converting into biliverdin. And there is one enzyme. I was not even asking about the enzyme, but the enzyme which is responsible for this conversion is heme oxygenase. Okay, and this biliverdin is getting converted into bilirubin. Now understand from where the bilirubin is coming, how bilirubin is getting formed. Fine. Any more doubts in here? and the enzyme which is responsible over here is the biliverdin reductase. The pace is fine now. You can understand how bilirubin is getting formed. This is how we are getting the bilirubin. Now, ma'am, you had a defect in understanding indirect to direct. Okay. Now, let's say, let me first write it down. In the liver, first in the bloodstream, and then in the liver. In the bloodstream, we have unconjugated bilirubin. In the liver, it's getting converted into conjugated bilirubin. Okay, I'm going back to that slide again. Yeah, in the bloodstream, what is there? Unconjugated bilirubin. Fine, it is converting into conjugated bilirubin with an help of an enzyme. What was that enzyme? Uridine glucuronide transferase. Why? How come this came to the bloodstream? Because it got bound with the albumin. Otherwise, it would have been in the reticuloendothelial cell system only. It bound with albumin, came to the bloodstream. Yeah, it is transportable now. Now it came through the bloodstream, came to liver. Once it is coming to the liver, in the liver there is one enzyme which is ready over there. Okay, to act. This enzyme is the uridine glucuronide transferase. Uridine glucuronide transferase. I can write it over here as well. Uridine glucuronide transferase. Okay. Now this enzyme which is present in the liver, it is converting the unconjugated bilirubin into conjugated bilirubin. Fine. Okay. Any more doubts? Anyone? Ma'am, in last, your doubts are clear? Fine. Should I remove? Okay. Anybody writing it? Please. Done? Done? Okay. Somebody tell me what is the importance of the negative Ehrlich test. Just raise your hand who knows. Raise your hands. Just raise your hands who knows what is the significance of the negative Ehrlich test. Don't talk among yourself. I can see you. You say. You say. Yeah. Stand up and say what is the significance of the negative Ehrlich test. If she helps you, she will go out. Who is teaching you tryptophan? Am I teaching tryptophan over here? No, right? From where are you getting tryptophan? Next to you, ma'am? Yeah? What is Ehrlich test is for? We are doing the Ehrlich test for which particle? You tell me. Yeah?
Test for urobilinogen.
Urobilinogen. Tell them we are doing the test, Ehrlich test for urobilinogen. How urobilinogen is coming into the gut? Let them. How urobilinogen is coming into the gut? You tell. You sit down. Yeah, with the gut bacteria, the direct bilirubin is getting converted into urobilinogen. Okay, so if the Ehrlich test is negative, means what? Urobilinogen is not there. Are you understanding? If the urobilinogen is not there, then only the test will be negative, right? If the urobilinogen is not there, means what? It is the bilirubin is not coming from the bile duct. Some obstruction is there. So if the obstruction is there, which type of jaundice is it? You tell me. Obstructive jaundice. So that is what is the significance of the negative early test. If the early test is negative, means first break down. Don't just get afraid after seeing the question. If the early test is negative, means what? We are doing the test for urobilinogen. Urobilinogen is absent. If it is absent, means what? Bilirubin is not coming. If the bilirubin is not coming, then the gut bacteria will not be able to convert it into urobilinogen. Right? So if there is some blockage is there, means what? It's obstructive jaundice. Whatever the cause is, it's obstructive jaundice. That's all. Fine. Are you clear, ma'am? Fine. Can you answer now? Okay, sit down. All of you sit down. With which protein does the bilirubin bind in for its transportation? Everybody should know. Raise your hands. Everybody should know. Who doesn't know? Show me the hand who doesn't know. You don't know.
No, I know.
Behind you. You don't know. You know. I am asking who don't know. Who don't know? Nobody will raise the hand even if they don't know also. I know it very well. Tell me the answer. Albumin. Yeah. Now, which bile pigment gives the green color in the Fouchet test? Biliverdin. And it is coming from bilirubin. What is the composition of the Fouchet reagent? Trichloroacetic acid. Please stand up. One question for you. Let's see if you can understand. Just use your common sense and then answer. Let's say one patient is coming to you with an obstructive jaundice. Okay? What will be the patient's stool color? Nobody will say. Nobody will say.
Definitely not yellow.
Yeah. What can it be?
Maybe white.
Yeah. It will be little whitish, little grayish. We say it as a clay colored stool. Anybody has any idea of clay? Those who are doing with pottery and all. The clay color, like little ash color. That color of stool with a sticky stool. Okay, so that kind of stool will be there. The patient will complain, sir, I am not having my yellow color stool, it is little clay color stool. Understandable? Good, sit down. So that will be there. Okay, anybody has any doubt from the topic can raise your hand and ask. From the whole topic, whatever I have taught. What topic I have taught? One is bile salts, bile pigments, and another one was the urobilinogen. Urobilinogen just to rule out obstructive jaundice. Bile salts, which test we did? Haze sulfur test. Okay. What was the salts? Sodium taurocholate, sodium glycocholate. Then we did bile pigments. What was the test? Fouchet test. What are the steps? Can anybody tell me? 5 ml of urine sample, 5 ml of barium chloride, 2 drops of glacial acetic acid, then filter the mixture. Once you get the mixture filtered out, then take the sample, add 1 drop of Fouchet reagent into it. If the color change is there, then bile pigment is present. Fine. Anybody has any queries? Anything? No? No? Okay.
The test of haze sulfur
Haze sulfur test for
bile salts.
bile salts. What are the bile salts?
Sodium taurocholate and sodium glycocholate.
Sodium glycocholate. Okay. And how much you have to fill the test tube with? 3/4 of the test tube. One of the test tube will be filled up with urine sample. Another one distilled water. Are we having distilled water? What are we filling up with? Tap water. So how it will hamper the result?
The sulfur powder will sink.
Sink. Why? Tell me.
Tap water.
Huh?
There is no presence of bile because of the presence of impurities.
Impurities in the water. Okay. In distilled water, what will happen?
Impurities.
Distilled water will have impurities.
No, distilled water will not have any impurities.
Yeah. Then what will happen? The sulfur will sink or float? It will float. In case of urine sample, it will contain what? If it is containing bile salts, then it will sink. Why? Bile salt will do what to the urine sample? You tell me. What about surface tension?
Surface tension. It will. If it is less than 3/4, then it will reduce.
You are saying whatever is coming in your mouth.
It will reduce the surface tension.
It will reduce the surface tension. The bile salt will reduce the surface tension of the urine, and then the sulfur will fall. Okay. In case of distilled water, there is no bile salt, so it will not reduce the surface tension and it will not fall. Fine. Yeah. Okay. Do the test. In two test tube, in one you are filling up with urine sample. and in another one you are filling up with the distilled water. Over here we are taking the tap water, but let's say it's a distilled water. In distilled water, is there bile salt?
No.
No. So it will not reduce the surface tension, so sulfur will float. In the urine sample, we are suspecting it is containing bile salt. If it is not containing bile salt, then the sulfur will also float. If it is containing bile salt, then the sulfur will sink. So if the sulfur is sinking, that means the urine sample is containing bile salt. Understandable? Yeah. Which test are we doing today? Haze sulfur test for bile salts. What are the bile salts?
Sodium taurocolate and sodium glycocolate.
Glycocolate, yes. What are the bile acids?
Taurocholic acid and glycocolate acid.
Yeah, simple. Those two are the acids which is reacting with the sodium and the potassium salts, and they are forming the sodium glycocolate, sodium taurocolate, potassium glycocolate, potassium taurocolate. Those are the salts. Okay. Now in the Haze sulfur test, what we are doing?
We need to take 2 test tubes
Yeah.
to fill it with 3/4 distilled water.
Hmm.
Test tubes.
Not in the both the test tube with distilled water. One will be filled up with distilled water. Another one, urine sample. Yeah.
We have to sprinkle sulfur powder.
Yeah. Then
Then we have to check. First, we have to check
if it is
whether sulfur
sinking or
powder is
not.
pure.
Okay. Let's say in the distilled water sulfur. Where is your urine sample? Over here. Okay. Did you add the sulfur already?
Yes, sir.
Yeah, it has fallen down. Whenever you are doing the test, remember one thing, do not shake. I told you there also, I am telling you once again, do not shake the test tube. If you are shaking the test tube, the test has no value to do. There is no point of doing the test. Okay. Take the test tube, fill it up, one with the urine sample, one with the water. Keep the test tube over here. Then fill the sulfur, jitteriness and some shakiness in your hand. That will not be there. Because you have filled up the sample, you have kept in the tray. Now you are doing with that sulfur powder. Okay, do it. बस चलेगा. Yeah, keep it. Now add sulfur. Yeah, this much is fine. Yeah. Is it floating? Yeah, it is floating. Why? The water does not contain bile salt, and that is why the surface tension is intact. Okay, and it is holding the sulfur above. আচ্ছা ঠিক আছে ফিল আপ হয়েছে টেস্ট টিউব খালি থাকে না আর What did I tell? What did I tell? You have filled up the test tube. Now what did I tell? Keep the test tube over there. So that you next time don't shake it again. Not this much. Listen. This is not a pinch. Okay. This much is pinch. The amount of froth is there. I doubt it will cross the froth. But if it crosses, as soon as it will touch the urine, it will fall. Okay, take the water sample now. It's floating, right? Over here there is so much of froth that it is not showing the test positive. Let me take out some froth. Now add sulfur. Now add little bit of sulfur into it. Do the test again. Add this much only. As soon as it touches the urine, it goes down. Understood? And why is it happening?
Surface tension is not intact.
Yeah. Why?
Presence of bile salt,
Bile salts. What are the bile salts?
sodium taurocolate and sodium glycocolate.
Okay, fine. Any doubts from the topic? Okay. What is the bile pigments? What are the bile pigments?
Bile pigments.
Say.
Bilirubin.
Yeah. Why he have to say you? Why he have to tell you?
I was just
Okay. What test are we doing for identifying the bile pigments? Not good. Tell me. Fouchet test. What is the composition of the Fouchet reagent?
ferric chloride and trichloacetic acid.
Okay. Now you tell me.